Okay, so now we're going to shift to Myelodysplastic Syndrome, and I'm going to talk about why we should think about doing transplants for people with Myelodysplastic Syndrome. And the consideration here is much like we have in multiple myeloma. So when you first encounter a myeloma patient, you sort of envision, is that patient a transplant candidate? And then if so, how can we best get them to transplant, and when should we do the transplant? In myelodysplastic syndrome, people haven't normally thought that way, but I think we should, because MDS is a disease that is not curable with standard treatment, even with the hypomethylating agents. And an allogeneic transplant does have the potential to cure these patients. It's a high-risk procedure, but we need to consider just when in the course of the disease one would want to consider an allogeneic transplant. So myelodysplastic syndrome is a family of hematologic malignancies with defective hematopoiesis and the propensity to evolve into acute leukemia. Recent advances in therapy, particularly the hypomethylating agents, have improved hematopoiesis, but still it's a disease that ultimately is fatal. Allogeneic transplants are potentially curative, and so the question is which patients should receive a transplant and when, and for the primary hematologist, is the patient a candidate for a stem cell transplant, and when should they be referred? So the first thing to consider when we're dealing with a patient is what's their prognosis with standard therapy. And a number of prognostic models have been developed. This is the IPSS scoring system. There's been updates to this in recent years, but basically patients can be broken into low, intermediate, and high-risk disease. And you can see that the low-risk patients, actually the colors don't correspond here, but the low-risk patients are the blue bar that have the best prognosis. The intermediate patients are in between, and the high-risk patients, you can see, do very poorly with a high risk of early mortality related to their evolution to acute leukemia or pancytopenia. That one can try to look at the IPSS score was to take people at the time of diagnosis and then apply the criteria. But our group at MD Anderson, this is a publication by Dr. Kantarjan and coworkers, have tried to look at patients and look at factors that can be applied during the course of their disease. I'm going to show you these here in a moment. And it's important to know that people who are previously untreated do better than patients who have been previously treated and failed therapy. So you can see the people with primary MDS untreated is this top line. People who've had secondary MDS actually have a worse prognosis, and people with treatment-related MDS, which is called secondary MDS in this slide, have a fundamentally worse prognosis, even if they have low-risk features by the IPSS score. So the IPSS scoring system does not include people with treatment-related MDS. And CMML is another category of MDS that has a poor prognosis. But the primary point of this slide is that if you've received initial treatment and failed it, now you go from this top curve to one of these lower curves where the median survival is only about 1 year, and most people have died within 2 years of that time point. So these are the unfavorable characteristics, having abnormal, unfavorable cytogenetics, age over the age of 60, and then blood count suppression, anemia, or thrombocytopenia, and increase in blasts. And you can see that they've assigned a weighting score for each of these. And you can see that the prognosis gets worse with a number of adverse scores that you see. So one of the things that should be considered as you're following a patient with MDS, if they've got falling blood counts or if they have increasing blasts, this should be a source of concern that their prognosis is now worsening. And you can see that the survival, once you get into the high-risk scores, is less than 1 year. So one of the seminal articles looked at the prognosis of patients with MDS getting standard therapies or stem cell transplantation. This is an article by Cutler, and coworkers back in 2004. So it really looked back in the transplants being done in the 1990s and early 2000 era. And you can see that if you eyeball the two curves, patients with low-risk MDS on the top who don't receive a transplant actually have a better survival than people who've gone through a transplant on the curves on the bottom. And that's almost self-evident. People with low-risk MDS don't have life-threatening cytopenias and have a lower risk of evolving into acute leukemia. So they have a fatal disease, but it is over a long period of time. It's an indolent type of malignancy. And the risk of the transplant in those patients is not warranted because the treatment-related mortality is too high in relation to the natural history of the disease. On the other hand, people with intermediate or high-risk MDS, you can see, have a poor prognosis with only a small fraction surviving to 5 years. And you can see that those results are improved somewhat with an allogeneic transplant, although one can see that we're saving only a small fraction of the patients. So 25 to perhaps 40% of people in the intermediate to high-risk category can achieve long-term survival with a transplant. This is better than you can achieve with standard therapy, but again, most patients do not benefit. So the one group that's sort of interest and debated is what to do with the intermediate 1 patients that have a intermediate curve where their median survival is in the ballpark of 5 years. Can we improve their outcome by doing a transplant, or could we select patients within that category that might benefit from a transplant? So this just looks at, from the Cutler analysis, the effect of delaying a transplant. You can see for intermediate and high-risk disease, there's more people dying if they don't get a transplant than if they do. But at least in this analysis, you couldn't show that doing a transplant for low-risk or the intermediate 1 patients was actually a benefit. Now, the other consideration in MDS is this is a disease generally of older people. You can see that the median age is up in the 70s, and so this is not a group that one can easily use myeloablative chemotherapy for. One needs to consider reduced intensity regimens, at least for most of the patients. So in our hands, we've used either melphalan fludarabine or busulfan fludarabine as a reduced intensity regimen, and we've looked at our outcomes. And here we've shown it in relationship to the WPSS. It's the World Health Organization prognostic system, very similar to the IPSS score. And I'll show you the outcomes here in a second. So that the people with the low or low intermediate disease actually have the best outcome. So again, if one can identify those patients and treat them early, you can achieve long-term survival in about 80% of those patients. Whereas if you wait for the patients to have higher risk disease, you can see that the outcomes are worse, but still some patients are long-term survivors even in the very high risk category. And so this is looking at patients with therapy-related MDS, and the same type of considerations hold, where depending on the number of risk factors that a patient has, being age, poor risk cytogenetics, transformation to AML, or a donor other than a matched sibling, you get increasing risk scores, and you can see that the outcomes for patients with 0 of these high-risk factors was actually quite good. About half the people are cured with an allogeneic transplant, whereas if you have all 4 adverse factors, you can see the prognosis is poor. But keep in mind, people with therapy-related MDS have a fundamentally worse prognosis than de novo MDS, and early transplantation is recommended. So that, like with acute leukemias, there is a graft-versus-malignancy effect that applies to MDS. It's a disease, at least in terms of its pathophysiology, very at least similar to AML in terms of transformation of hematopoietic cells, increasing blasts in the bone marrow, and that the same kind of rationale can be made for the using non-myeloablative treatments with a goal of trying to utilize the graft-versus-malignancy effect as our major treatment modality. And so the data that I showed you with in terms of our own survival curves, again, was with the use of these reduced intensity regimens. So the major question is when you encounter a patient, what's the goal for that particular patient? Are you going to try for a cure of the disease, or is this a patient that would be best suited with palliative measures? If they're older and have comorbid diseases, one may well consider a palliative approach that might be more appropriate for that patient. On the other extreme, a younger patient in good condition who has a long life to live, if they could have their underlying MDS controlled, one would consider that patient highly for an allogeneic transplant. What are the logistics of the transplant? You need to be near the transplant center. You need to really be committed to going through the supportive care needed for a transplant. So this is not necessarily a treatment everybody can consider just from their own life circumstances. And you need to be prepared to take on the risks related to the transplant. And the transplant might, in fact, shorten the lives of some patients if they have major complications. So the decision in an individual patient really depends on the patient's goals as well as their prognosis with and without a transplant. In the United States, we've had lots of discussion whether the government's Medicare system should cover MDS, and we've actually been able to get that condition now covered because we've been able to show that the results of allogeneic transplants are actually as good in people over the age of 65 as they are in younger patients. And this is a multi-center study published in the Journal of Clinical Oncology where you can see the outcome in patients over the age of 65 is really about the same as in patients from 40 to 60. One of the interesting thought is if azacitidine is a good treatment for MDS to improve hematopoiesis and potentially delay transformation to acute leukemia, couldn't we give it after the transplant as a way to keep these patients in remission and prevent their MDS or AML recurring after a transplant for myelodysplastic syndrome? So we've actually done a phase 1 study of azacitidine post-transplant. It's a challenge to give any treatment post-transplant during the period of immunosuppression and risk for graft-versus-host disease. But we found that we could, in fact, administer azacitidine 32 milligrams per meter squared, about half of the MDS dose, given that daily for 5 days on monthly schedule. And if we looked at the results of the patients in the phase 1 study of the azacitidine compared to our historical controls that were the similar type patients that did not receive azacitidine, there is actually an advantage to those patients. And that we're now in the midst of a randomized trial to hopefully confirm that, in fact, there is a benefit for this rationale in treatment. So in conclusion, I would say that transplants are clearly indicated for patients with intermediate to or high-risk MDS on the basis of the Cutler data that I had presented to you. For patients with intermediate 1 MDS by the IPSS score, the results have been improved in single-center studies such as our own, and I would recommend considering transplant early in the course, particularly if the patients have failed to respond to hypomethylating agent therapy. This is a question that needs to be directly addressed, and we're trying to look at our own data to call that out, because patients who have failed to respond to hypomethylating agent therapy actually have a poor prognosis. And then patients with low-risk MDS, the initial conservative therapy is warranted in those patients, but they should be considered if one sees any signs of deterioration and acquisition of any of those risk factors I had showed you earlier. So with that, I'll close, and maybe we can defer questions until after our debate.